Bismillahirrahmanirrahim. Today we will have case quiz number 17. Case data: 41 years old African female. The initial symptoms are burning and stinging of the upper body for over 4 weeks. Burning and stinging of the upper body for over 4 weeks. Progressing to dark, firm, painful areas on chest, neck, and abdomen with sclerodactyly, with negative symptoms including no tightness around mouth, no dry eyes or mouth, no arthritis, no dysphagia, no Raynaud's. So these are the negative symptoms. Physical examination: dark brown indurated nodules with slightly violaceous borders over the chest and the breasts, along with smaller hyperpigmented plaques scattered over the abdomen. Extensive hyperpigmentation and skin tightening over the anterior neck, chest, axilla, and abdomen. Contracture of the left hand's fourth and fifth digits with a slight tapering of the fingertips. The face is free, with no telangiectasia. Investigations showed CBC was normal, ANA was highly positive, with a titer of 1/1280 by immunofluorescence. Anti-Rho positive, anti-La positive, anti-SCL70 negative, anti-Smith negative. Therapeutic history: the patient was treated with methotrexate 17.5 mg weekly, which resulted in moderate improvement. So it is scleroderma, but not typical scleroderma. So what is this case? So what is the diagnosis? As usual, you can stop here, try to search for the answer, and then replay the video. The answer is I said it is a subtype of scleroderma. Yes, it is correct. It is called keloidal scleroderma. Keloidal scleroderma. Keloidal scleroderma is a very rare diagnosis, which has been also reported with alternative nomenclature including keloidal morphia, nodular morphia, and nodular scleroderma. Keloidal scleroderma presents as multiple keloid-like lesions that occur in the absence of preceding trauma or injury and can be associated with localized or systemic symptoms of scleroderma. This is in contrast to the flat and or depressed plaques associated with tightening of the skin that is seen in classical cutaneous scleroderma. Histopathological findings in keloidal scleroderma can be variable. This photo shows the case in our interest in this video. This is the case of keloidal scleroderma in 41 years age, female African ethnicity. As we see, there are multiple scattered and hyperpigmented nodules overlying plaques along the trunk and upper extremities, with less extent on the abdomen. The most common extension is in the axilla, upper chest, and neck. Clinical data of recorded 43 patients from 92 different populations is presented in the next table. The majority of patients were African American and female. So This is a very rare condition recorded only in around 43 cases all over the world. Most of them are African American, age ranged from 3 to 70 years, with a median of 41 years. 90% of cases have nodular lesions with distribution on the trunk, while one case had lesion in the intertriginous area. The majority of patients presented with sclerodactyly as well as extracutaneous manifestations of systemic scleroderma. Pulmonary involvement was reported in 28% and renal involvement in 5% of cases. 10% of cases noted an external trigger prior to the onset of keloidal plaques, including infection, D-penicillamine administration, tetanus vaccine, and environmental exposures. This table shows the characteristics of the 43 cases recorded. 70% were females, more than 59% were African American, 30% Caucasian, 7 Hispanic, and 4 Middle Eastern. Clinical manifestations: the most common is sclerodactyly in 58% of cases, renal in 47%, arthritis 30%, pulmonary 28%, esophageal dysmotility 23%, and renal involvement in 5%. Distribution: the trunk was affected in 91% of the cases, nearly all of the cases, acral in 60%, head and neck in 35%, and intertriginous in 2%, actually one case. External trigger was seen in 10% of the cases, I mean 4 cases out of the 43 cases. ANA was positive in 63% of cases, elevated ESR in 15%, and positive anti-SCL 70 in 10% only of the cases. Take-home message: diagnosis of scleroderma should be considered in a patient with extensive keloids. Due to this being a rare variant, our knowledge of treatment options and efficacy is limited. Methotrexate could be considered as an initial treatment option for patients with progressive keloidal scleroderma. Further research is still needed to understand the pathogenesis and treatment of this rare variant of scleroderma. And finally, thank you very much for your attendance, and we will meet you in the next future with case quiz number 18. Wassalamu alaikum wa rahmatullahi wa barakatuh.